Hello, my name is Ali Nirodi, and this is a presentation on Esmolol. Esmolol is a beta-1 selective or cardioselective beta-adrenergic receptor antagonist, also considered to be a class 2 antiarrhythmic. Its brand name is Brevibloc, and it comes as an aqueous solution and is only available for IV use. Beta blockers exert their mechanism of action at beta-adrenergic receptors. Beta-type adrenergic receptors are G-protein coupled receptors that regulate the activity of intracellular second messengers. The beta-adrenergic GS receptor activation by agonists triggers adenyl cyclase to generate cyclic AMP. The increased levels of intracellular cyclic AMP stimulates a cascade of effects that results in the increased influx of calcium into cells. Beta-adrenergic receptor antagonists selectively bind to beta receptors to prevent receptor activation by catecholamines and sympathomimetics. Beta blockers function as competitive inhibitors at beta-adrenergic receptors. As class 2 antiarrhythmic drugs, beta blockers diminish sympathetic stimulation of the heart and decrease the rate of spontaneous phase 4 depolarization and SA node discharge. Beta-1 receptors are located on the heart and the JG cells in the kidney. Stimulation of the beta-1 cells or receptors results in increased rate and force of cardiac contraction and increases in the release of renin. Beta-2 receptors are in tissues of the lungs, uterus, and vascular smooth muscle. Stimulation of the beta-2 receptors results in smooth muscle relaxation. Beta stimulation can also produce glycogenolysis, lipolysis, and relaxation of smooth muscle located in the GI tract and the bladder. Beta blockers can be categorized based on different properties. Non-selective beta blockers exhibit affinity for both the beta-1 and beta-2 receptors. Use of the non-selective beta blocking medications have increased risks of respiratory side effects due to their ability to block the beta-2 receptors. Examples of non-selective beta blockers are propranolol and timolol. Beta-1 selective medications predominantly bind to beta-1 receptors and result in cardiac effects and are termed cardioselective. Competitive inhibition of the beta-1 receptor results in decreased cardiac conduction through the AV node, decreased heart rate, decreased cardiac inotropy, and therefore decreased cardiac tissue oxygen demand. Examples of cardioselective beta blockers are metoprolol, atenolol, and esmolol. Beta blockers can also be categorized based on their intrinsic sympathomimetic activity. Beta blockers with this activity have partial agonist actions at the beta receptor, and these medications are principally used to decrease blood pressure. Some examples are acebutolol and punolol. Some beta blockers have demonstrated membrane stabilization properties. These effects resemble the actions of local anesthetics by reducing the propagation of action potentials. Propranolol exhibits this membrane stabilization property, but only happens at doses that are much higher than they're actually clinically used for administration. The side effects of beta blockers are generally related to the cardiovascular system. The negative inotrope and chronotropic effects of beta blockers can result in severe bradycardia or hypertension. Significant hypertension can occur if the beta blockers are administered with alpha-1 agonists such as epinephrine. The beta blocker prevents the vasodilating effects of epi at the beta-2 receptors, leaving unopposed alpha-1 mediated vasoconstriction. Abrupt withdrawal or discontinuation of the beta blockers after chronic or prolonged therapy can result in increased sympathetic activity due to upregulation of beta-adrenergic receptors. The use of non-selective beta blockers or cardioselective blockers at high doses can increase airway resistance and result in bronchoconstriction. This side effect is often amplified and can be fatal in patients with reactive airway diseases such as asthma or COPD. Beta receptor antagonism can result in alterations in fat and carbohydrate metabolism, and the sympathetic blockade produced by beta blockers can also conceal symptoms of hypoglycemia. Therefore, administration to diabetics is a relative contraindication. Beta-2 antagonism also blocks the cellular uptake of potassium, which can result in increased plasma potassium concentrations Some beta blockers are lipid soluble and can therefore cross the blood-brain barrier to produce adverse effects in the CNS. These are often mild sedation, vivid dreams, and can infrequently cause depression. Beta blockers have also demonstrated the ability to cross the placenta and exert adverse effects on newborns. The main contraindications for the use of beta blockers is in patients with pre-existing AV heart block because they slow conduction through tissue in the atria, causing prolongation of the PR interval. Other contraindications to beta blockers are bradyarrhythmias, bronchoconstriction, and acute heart failure. Caution should be taken when administered to patients with Raynaud phenomenon due to the risk of increased peripheral vasoconstriction. There are many indications for the use of beta adrenergic antagonists. Chronic therapy with beta blockers is often indicated in the treatment of hypertension and migraine headaches, and for the management of angina pectoris and congestive heart failure. Patients taking beta blockers should not discontinue the medication prior to surgery to prevent withdrawal hypersensitivity. Beta blockers can be administered preoperatively to patients with hyperthyroidism or during a thyroid storm, and they can also be administered IV for the treatment of acute coronary syndrome. Beta blockers have been used to attenuate the increased sympathetic activity associated with surgical stimulation, and perioperative use of beta blockers is to treat hypertension, myocardial ischemia, suppression of dysrhythmias, management of pheochromocytoma, and can be utilized as an agent for deliberate controlled hypotension. Beta blocker overdose can cause extreme myocardial depression, bradycardia, hypotension, cardiogenic shock, and bronchospasm. Glucagon is often the preferred treatment for beta blocker overdose because it acts independently of beta receptors to increase intracellular cyclic AMP concentrations and can be administered at 1 to 10 milligram IV boluses followed by an infusion running at 5 milligrams per hour. Esmolol, again, is a beta-1 selective antagonist that's only available for IV administration. It lowers the heart rate via reduction of the sinus rate, decreases AV node conduction, and results in a decline in cardiac inotropy. The selectivity exhibited by esmolol for the beta-1 receptor is dose-dependent, thus extremely high doses have the potential to result in beta-2 antagonism and possible bronchoconstriction. Esmolol does not exhibit any partial agonist activity or local anesthetic action. The chemical structure of esmolol contains an ester linkage. The ester linkage is quickly metabolized by nonspecific plasma esterases located in the cytosol of red blood cells. Esmolol has an onset of action of 2 minutes, an elimination half-life of about 9 minutes, and a duration of action of about 10 to 15 minutes. The plasma esterases responsible for the metabolism of esmolol are not the same plasma cholinesterases that metabolize succinylcholine. Metabolism of esmolol results in an acid metabolite with minimal activity and minor amounts of methanol. Less than 1% of unchanged drug is found in the urine, while 75% is required as the acid metabolite of esmolol. Esmolol has many unique uses in anesthesia. Its short onset and duration of action make it an ideal medication to administer IV and titrate intra-op. Esmolol is often used to treat increases in sympathetic activity in response to stimulation. Doses between 100 milligrams and 200 milligrams can be administered over 15 seconds before anesthesia induction. And then when administered at 0.75 milligrams per kilogram and given 1.5 minutes before induction, esmolol has been shown to blunt the increased sympathetic response related to increases in desflurane concentrations. Esmolol can also be used perioperative to treat tachycardia and hypertension. The standard initial dose is 0.5 milligrams per kilogram IV over 60 seconds, followed by an infusion of 50 to 300 micrograms per kilo per minute. And esmolol can also be administered in small IV doses of 10 to 15 milligrams as needed. Esmolol can be used as an adjunct during deliberate controlled hypotensive techniques. And a common dose of this is 200 micrograms per kilo per minute to attain a 15% reduction in MAP Due to its activity as a Class II antiarrhythmic, Esmolol can also be administered for the treatment of SVT. Initial IV bolus of 500 micrograms per kilo is given over 1 minute, followed by an infusion of 50 micrograms per kilo per minute for 4 minutes. Esmolol has also been shown to be more effective in converting AFib to a sinus rhythm than the use of verapamil. There are many anesthetic-sparing effects of perioperative administration of Esmolol. It was found that propofol requirements were decreased when Esmolol was administered in large quantities. Volatile anesthetic gas requirements are lower when Esmolol is administered with opiates. And the use of perioperative and postoperative opioids was decreased with Esmolol use. The exact mechanism of pain modulation by Esmolol is unknown, but one of the theories points to the possibility of decreasing opioid metabolism and therefore increasing the duration of action of opioid analgesics. Other theories point to central action by increasing fentanyl penetration into the CNS, or possible modulation of neurotransmitter release in the substantia gelatinosa. Clearly, perioperative use of Esmolol can be beneficial when utilizing a multimodal approach to the management of pain. The main side effects of Esmolol are related to its effects as a beta-1 adrenergic antagonist. These effects are often hypotension and bradycardia and are often dose-related. Esmolol can sometimes cause nausea, but rarely results in vomiting. And then bronchoconstriction and other beta-2 side effects are rare, but can be possible if high doses of Esmolol are administered. Esmolol is a vesicant, and extravasation can cause irritation and inflammation. If this does occur, the infusion should be discontinued. The extravasated medication should be gently aspirated, and the extremity should be elevated. The contraindications of Esmolol reflect the contraindications to beta blocker administration. Esmolol should not be used in patients with bradycardia, AV heart block higher than first degree, cardiogenic shock, or acute heart failure. Esmolol should not be administered along with verapamil or diltiazem due to the combined effects of reduction of heart rate and contractility. Then caution should be taken when administered with digoxin, as bradycardia or heart block are possible. Esmolol administration to hypovolemic patients can attenuate reflex tachycardia and result in profound hypotension. Doses of Esmolol are not adjusted for renal or hepatic impairment due to its mechanism of metabolism via plasma esterases. UpToDate stated that the administration of Esmolol in neonates and pediatrics should be titrated to individual response and tolerance due to the limited availability of data regarding dosing. Bradycardia may be seen more frequently in geriatric populations, and they may require lower doses of Esmolol. And here are my references, and thank you for listening.